everyone. So first I want to start with thank you to organizer Chip and Ivona for allowing me to talk on this topic. So this is truly a question, and I don't pretend I know the answer to this. What I hope to do is through some cases and also some experimental data to really bring this question to a different level and ask additional questions, see how we can all address this ultimate question altogether. No disclosures. So from the universal source of truth in Wikipedia, this is the definition of a carrier, right? So a carrier, they define as a person who inherited a recessive allele of the genetic trait, very nicely said, usually does not display the trait or show the symptoms of disease. So if you plug this into DADA2, you would see something like this usually, right? Healthy individuals have lots of ADA2 on the green bar. Carriers have midway in terms of activity. Neither should display symptoms of the disease. Whereas when you don't have ADA2, you have the manifestation of the disease. But every now and then, unusually, you get a case, something like this. If you plugged in the ADA2 scenario where it's a gradient, right? You have people have very high levels of ADA2, and then all the way to people that have no ADA2, right? So in health people, typically you don't have symptoms. In the carriers, you may display some symptoms because the levels are lower than the homozygous normal individuals. So I think overall, just listening to some of the other speakers this morning, that I think generally we're favoring the latter scenario here. And there are some evidence in the literature to support that. So from Dr. Cotono's cohort, although they seem to have solved some of these patients' other mutations at this point, they found a few patients where they had low or no activity level and have some phenotype of the disease. From the recent French cohort, there is a patient of G47R that's heterozygous and had a sort of a milder case of the disease. And Oscar presented ACR, this is from the NIH studies, where in adult patients with PAN, a number of them have biallelic or also monoallelic mutations of ADA2, also suggesting that having one mutation is at least associated with findings of vasculitis. So before we get into some of these cases that I was involved in, I want to recognize some limitations to study carriers. Right, so first, there's no really good published studies to study large cohort of carriers altogether. And ADA2 deficiency is heterozygous in terms of their manifestation is purely heterogeneous, right? So these cases of heterozygous individuals, their symptoms typically milder, so it's even harder to study this. And if you tell someone you have a pathogenic mutation that's could lead to a disease that's potentially fatal, could that influence their sort of subjective recognition of symptoms? And ultimately, we don't know the denominator, right? So we know a lot of patients, we know their parents are likely carriers, but how many of these people are out there walking around with just one mutation? Right? For example, in the Israeli cohort, where 10% of the people may have G47R, but in the rest of the population, we're talking about 1 in 10,000 individuals with this particular variant. And also, at least in pediatric rheumatology, we're now facing a large amount of sequencing data of these variants of unknown significance, right? If you get one of these for ADA2, is it pathogenic, right? If it's associated previously with mutations, sure, but if it's a new variant, do we know, is this patient a carrier? So with that in mind, I'll walk you through a few cases, and then also I can show you some data to elaborate on the scenarios. So the first case I saw recently is a 4-year-old girl with periodic fever episodes. And she comes in with this fever of every 4 to 6 weeks, the last 3 to 5 days, fairly benign. Every now and then she has a little sore throat, but really no other symptoms to go along with it. And when you check her labs, she has a little bit of anemia, hemoglobin of 10, that's persistent. CRP and ESR is persistent elevated. Brain MRI was normal. So in pediatric rheumatology, we see this quite often, frankly, although the labs are typically only inflamed during these episodes, but this looks a lot like something we call PFAPA. Sorry, let's go back. So she's otherwise doing well, growing normally, so we'll just continue to observe her and bring her back to her for a follow-up. But since this was going on long enough for a couple of years, we decided to do a genetic panel for fever syndromes. We ruled out most of the other causes of fever syndrome, except we did find a variant of G47V, which of course has been found in one of the initial cohort of DADA2 patients. Using Mike's assay, that we can also see that the patient is truly heterozygous. Green light. On the left here, the patient's father also has heterozygous level of enzyme activity. So looking at the genotype, it seems that she is truly a heterozygous patient. Now, is that related to a fever episode? Right? Not something we know for sure. Second case is a 25-year-old young lady with constellation of rash, Raynaud's, and some evidence of immunodeficiency. So she was fine when she was just 12 when she developed skin rash that looked a lot like what the doctors call hypersensitivity vasculitis. There's a biopsy done that shows some paravascular lymphocytic infiltrates, but it was read as nonspecific. Then she developed symptoms of arthritis, particularly in her small joints, Raynaud's, elevated inflammatory markers, and ANA that's always positive, which you see in some of the DADA2 patients. As a early adolescent individual, she developed esophageal candidiasis, right, that ultimately lead to an immune workup that show borderline IgG levels. We'll go back. And suboptimal response to pneumococcal infection, immunization, and also poor lymphocyte proliferation. So she was thought to have either an undifferentiated connective tissue disease or some type of immunodeficiency that looks a little bit like CVID. So she started on IVIG, and she seems to be doing okay. So these are some of the pictures from this patient, where you can see the really profound Raynaud's of her fingers. She has these subcutaneous nodules that looks a little bit like perneal, but they are certainly painful and can occur independently of her Raynaud's. On the lower left, you see arthritis of her PIP joint, and in the last picture is the esophagus showing candidiasis. Confirming this so there's this gene panel again found in this patient, and this patient has a G47A mutation, which in a Caucasian population is less than 1 in 10,000. And by Mike's Hershey's assay, she's also shown to be a carrier by reduced but not absent ADA2 activity levels. Page 3, it's a 49-year-old female. Now, she's a known carrier at the basis of having children diagnosed with DADA2. So she has a long history of migraines for about 10 years, where she gets retroorbital pain, numbness, nausea, and photosensitivity. Then later on, she developed joint pain, morning stiffness consistent with small joint arthritis. That is to the point that's debilitating, interfering with her daily activities. She's rheumatoid factor negative, has elevated inflammatory markers, and had a normal brain MRI. So she was diagnosed with seronegative RA in addition to migraine headaches. So ultimately, with her joint symptoms, she was started on adalimumab with significant improvement of both her joint symptoms as well as her migraines. And this family has been published previously, where we have 2 children here, with 2 different mutations, and this is the carrier individual on the right of the K55 the deletion that we're discussing here. So confirming that these mutations are pathogenic, the activity assays show carrier level activity for both the patient and also the spouse, and then the absent level for the children. So next is a case followed by Dr. Grayson at NIH here. Gracious for sharing the slides. This is another family where they had 2 children, right, with DADA2, and the mother of the patient had lacunar stroke at age of 45, had foot drop, significant joint pain, and also elevated CRP. Interestingly, there's a grandmother of this patient that had biopsy-proven PAN, disease, so I'm not sure if the genetics is clear in that regard. And lastly, the most profound case I've seen as a physician at Boston Children's is this 17-month-old boy that came to us with viral sepsis and later on a brain hemorrhage, which seems like 2 unrelated entities. So at 18 months of age, he presented with fever, rash, and rapidly declined and progressed to cardiac arrest. After a few minutes of resuscitation, the patient was stable and remained in ICU for a number of days. And credit to the ICU nursing staff, where at the basis of having asymmetric pupil reflex to light, they thought something was unusual and got an MRI. And that showed a significant hemorrhage on the right frontal lobe. I'll show you the picture on the next slide. And this patient was left with significant left hemiparesis, and if we look carefully, he does have livedo as well. At the time of presentation, when we thought he had sepsis, he certainly had pancytopenia and also elevated inflammatory markers. So the initial diagnosis was viral sepsis, but a lot of this looked a little bit like DADA2, certainly, I would agree. The patient was started on corticosteroids in this treating of sepsis-related inflammatory response. And ultimately, with the bleeding, we switched to etanercept. He's out off all steroids, all labs are normalized, and he's almost walking again, which is remarkable considering this image we're seeing here. Right? So this is an MRI, not a CT, because there wasn't, the concern for this pupil reflex was not bleeding at the time, so we got an MRI. And even a rheumatologist can tell you this is not normal. Right? On the left here, you can see significant mass effect of the right frontal lobe that's impinging on the left side, and also you can see a large area of ischemia over here as well. So this patient was taken to neurosurgery immediately. Almost the entire right frontal lobe had to be taken out because of the massive necrosis from the bleed. And so at 4 months follow-up, you can see this, this area is filled with fluid at this point, and most of the frontal lab, again, has been removed. So it's unusual enough and has some resemblance to DADA2 that I pursued, what was this level like? So working with Mike Hershey again, and now doing this in my own lab here at Boston, that we can show that this patient had, again, carrier level, on the left here, an arrow, of ADA2 activity in the blood. And I've tested this patient probably 5 or 6 times. Before and after TNF inhibitors, the level never changes, right? It's consistently present but low. Interesting, the mother and father both have low levels, right? Consistent with carrier status. And going beyond that, looking at the grandparents who are all alive, one grandparent on each side have low levels, right? So this doesn't really look like an accident by any means. And putting the map together, we can, on the pedigree together on the right side. So working with Ivona, we're trying to sequence this patient. I was sure that we're going to find 2 mutations for this trial, even though there's a little bit of cross activity. And in fact, we found none, right? This patient has no identified variant. Although we were able to identify a novel deletion in the father that was not present in the trial, right? This is remarkable in the sense that this trial probably has maybe a mutation in ADA2 that's present in the mother and the maternal grandfather that we're still not able to find at this point. But certainly by the activity, it's fairly convincing that this patient is a carrier, right? So this raised lots of questions than what I started with, this simple question, right? So how should we define a carrier, right? Do we define carriers simply because they have one pathogenic mutation, or do we require that they have one pathogenic mutation? Knowing that most cases we know as carriers are individuals who have one or more family members diagnosed with disease. We do have some limitations in that regard as well, in that not all mutations can be identified, right? Even with the best technology available, we're still discovering new mutations every day on patients that we previously thought are heterozygous. And also, not all variants are pathogenic, and I'll elaborate that on my next slide. Now, should we incorporate the activity assay? Dr. Youngstein spoke to this point earlier on the assay. I think that that's a good approach, right? A reduced level certainly will support heterozygous loss of function mutations. But there are also limitations to that, right? The barriers or the cutoff between a carrier and a healthy control, right? It's an artificial definition, right? I truly believe there's enough heterogeneity where the phenotype of any ADA2 plasma level is really a true spectrum, right? There are people that have no mutation that may have lower level, and people have no mutations, or healthy people that have lower levels by default. So there are probably other factors we haven't identified yet that can affect ADA2 activity, certain cytokines, certain environmental factor that can influence ADA2 expression activity at a given moment as well. So in terms of thinking a little bit about this concept that not all variants are pathogenic, so this is a functional assay that I've worked on in the lab, where in the world of single cell sequencing and all that, this is old school cloning, right? Restriction enzyme cloning, putting ADA2 into expression vector and express it in 293 cells and see what happens, okay? What you can see is ADA2 gets expressed, gets released to the cytoplasm, and you can measure activity in the cytoplasm using the same assay that Mike Hirschfield uses at Duke. And then we can measure the activity, we can do Western blot, we can do a lot of different things. So these are the top 10 missense variants of this disease identified in the genome aggregation database. Some of these are very common, so I'll show you here the MAF here, and one in how many individuals do you see this? Okay, so the most common variant is H335R. So 1 in 3 people, right, have this. So this is probably not considered a pathogenic variant. And in fact, if you express this in cells, the activity level is actually a little bit higher, about 20% higher consistently than the healthy wild type copy of disease. Then you start walking down to different variants where, interestingly, you get into 3M09I, right? This is I can't point it here, but it's the 4th bar down there. You can see this is present in 1 in 600 individuals, right? And this mutation gives you a halfway reduction of ADA2 activity. And if you look in literature, this mutation has been identified in a few patients with Behçet's syndrome, and also in one of the PAN patients in an NH cohort. And going down further, there's another one that's 435, and then you see 2 well-known mutations in R169Q and G47R, and those certainly have 0 activity at all. How well do these computer algorithms predict these mutations? Not very well, right? So the really pathogenic ones are 69, yes, that's correct. G47R, that's correct between polyphen and CIF predictions. But some of these are, it's debatable between these 2 computer algorithms. And interestingly, with the P35L, second to the last one, that's been identified in a couple of DADA2 patients. But at least on this assay, using 293 cells, their activity is only reduced by about 20%, really unlike the other DADA2 mutations. And lastly, I want to bring up this concept that's probably novel, is that ADA2 may be a dominant negative disease because they form dimers. Okay, what about the scenario where you have one mutation that forms a dimer with the wild type copy? What happens to that, right? And we're going to address this using a co-transfection assay by tagging MIG-tag with the mutant and then also the hemagglutinin tag with wild type and co-transfect and see what happens we co-express a mutant with a wild type, what happens to wild type expression levels? And what you can see is if you make a mutant in G47R, which is affecting the dimerization domain, the level goes down a little bit. But if you get a mutation that affects the enzymatic domain, it's Y453C, the reduction of the wild type activity goes down by about half, right? So having a mutation can actually affect the function of the wild type. And this is the sort of actual assay showing that depletion of adenosine using the Mike's assay to see transfecting wild type gets you very good activity. Putting in the mutant together, it gives you sort of a halfway reduction of that activity. So with that in mind, this is my conclusion slide. So really I ask to address the question to you, how should we define these carriers and should we treat them, right? This is probably a case where we have to, a question we have to address on a case-by-case basis, right? We're thinking whether the symptoms simply periodic fever or do they have a full-blown stroke that's more suggestive of the phenotype. Again, we should gather all of experience together to really answer this question in a meaningful way. We should have an algorithm to determine who truly is considered a carrier. Should we do genetics or should we add on the enzymatic assay? And we should find a way to study this at all of us together in a systematic basis to really see how common are these findings in the context of these carriers. So with that in mind, I'll acknowledge some of the collaborators. Thank you.